So the impact of dual versus single anti-HER2 blockage, a real-world retrospective analysis of treatment outcome in Bangladesh. And this is the agenda. I think we'll try to touch everyone. And if we find the clinical challenge for the HER2 positive breast cancer is always aggressive type, and HER2 targeted therapy has revolutionized treatment, improving prognosis dramatically, and trastuzumab the fundamental anti-HER2 over 2 decades. The combination of trastuzumab and pertuzumab has shown superior efficacy in clinical trials. So why the real-world data from lower middle-income countries are critical? The clinical trial is always establish the efficacy and safety in highly controlled and selected population. So in the real-world practice, the patient demographics and tumor characteristics may differ. Access to therapy and follow-up are often limited, and cost can be significant barrier to treatment. So why the study rationale, we aim to understand if the benefits of dual blockade seen in trials translate to resource-limited setting in Bangladesh. We all know the management ESMO guideline about the HER2 positive early breast cancer, where to give the trastuzumab and when to the combination of trastuzumab, pertuzumab, and what for the after surgery in case of PCR. So the importance of multidisciplinary teams are essential for the management of patient with HER2 positive breast cancer. This is now well established that for the patient factors, for the tumor characteristics and staging information, the MDT board can plan for the neoadjuvant and surgery upfront well. If we try to find the PCR status across the hormone receptor positive, luminal A, luminal B, and triple negative, we always see that the PCR rates is corresponded the survival outcome or event-free survival, especially in the HER2 positive subtypes in the studies. And the dual HER2 targeted neoadjuvant regimens have improved the PCR rates comparing the trastuzumab plus chemotherapy alone. In the NeoSphere trials, it is 39.3% PCR rates, and in the Trifina, 63.6% PCR rates achieved. And development of PCR rates following neoadjuvant chemotherapy plus anti-HER2 treatment in all phase 2 and phase 3 trials achieves the consistent PCR rates. So this is our study which happened in the Bangladesh Specialized Hospital, and the other members of the study shown here. The study design was retrospective cohort study, and the timeline was quite big, 2017 to 2025. 84 patients included for this HER2 positive breast cancer patients, and the number for the dual blocker is 33, that is 39%, and for the single blocker 51 is 61%. And we make this 2 arm in the 3 subgroup, that is neoadjuvant, adjuvant, and metastatic, where consistent number of patients is there, but not. Our endpoint is PCR event-free survival and OS for 3 years, and cardiotoxicity and site of metastasis. The methodology already described, and if we see the 3 arms distribution, the PH neoadjuvant and the neoadjuvant arm contains 40 patients with a balanced arm in PH and H group, but in the adjuvant and metastatic, that is not well balanced due to the retrospective study. And if we see the patient demographics, median age is 53 years, only 1 male patient was included, left-sided dominant as well as bilateral case 4.7%. And if we see the luminal criteria in the single age and dual blocker, the median age was 54 for the single and 51 for the dual blocker. The ranging is from 28 to 75 and 34 to 62. Stage also 1-2 patients are very high in our study, as well as stage 3 patients included for the neoadjuvant settings. So other findings, we try to find out the family relationships, the first degree, second degree relatives are involved, and Some don't have that, but most of the patients are unknown because we did not collect the data earlier for the family history. We tried to explore the BRCA studies and it only found 3 patients negative and most of the patients are not done, but now we are focusing for the BRCA data as well. And definitely the invasive ductal carcinoma is the predominant and the grade 2 is the higher incidence. The T stage 2 is the biggest number as well as N1 and combined stage 2 patients are most of them. So the most predictive factors for our neoadjuvant group, the pathological complete response, we clearly see that the PCR achieved in the dual blocker plus chemotherapy arm 64.8%, while in case of the single blocker 30 plus chemotherapy arm 38.1%. And higher PCR rates, I already shows the evidence that may indicate the better treatment efficacy. So we use the chemo regimen, sometimes AC free and with including AC as well. If we see the neoadjuvant settings, it is well balanced and AC free regimen shows the survival benefit rather than AC group as well as in case of adjuvant, but metastatic group shows that there is AC group is better than. There is also a luminal B group patient in this study, so the people who are luminal B, I think the AC group dominate the survival case. If we combinedly see the histogram of the survival, the median survival was 73 months and in case of the group, grade group, some grade, we completely clearly see that grade 4 groups survival, Kaplan-Meier survival curves did not achieve in case of grade 2 or grade 1. And stage-wise survival also we can see. Here the group stage-wise survival shows the Kaplan-Meier curve consistently lower staging patients in the higher survival rates as well as the higher stage 4 group was doing the worse survival in the Kaplan-Meier curve. But in stage 3B patients, the PCR rates is higher rather than other stage group. This is the bizarre slide, but the forest plot for the hazard ratio, we try to achieve plot and we found that the N stage and T stage lower. When the N stage and T stage are lower, the hazard ratio is good, but in case of some sparse data, the hazard ratio is not much significant. So the survival outcomes, overall survival 8 deaths total, and single blockers, in case of single blockers it is 11.8% and dual blocker it is 2 deaths. And if we see the disease-free survival over 3 years, the PH group has 86% in neoadjuvant arm, where the trastuzumab group has 92%. But the adjuvant group did not achieve the lowest recruitment of data. And in case of metastatic one, where survival was 67% and Herceptin group has had 100%. This is the Kaplan-Meier group in our subgroup analysis. The 3 year survival for the dual blocker is 100%. That is quite a little bit higher than the single blocker. And disease-free survival I already mentioned earlier. This is also in the adjuvant settings. The data is not that much due to recruitment for the dual blocker, only 4. So it is not much reflected. So the recurrence pattern, when the recurrence happened and the de novo metastatic case, we found most predominantly in the lung, bone and liver, as well as brain. I think brain observed in both groups, 6 in dual blocker and 3 in some other points. And the cardiotoxicity is the main concern for treating the anti-HER2 therapy along with chemotherapy. So the AC-free always gives some benefit, we know, and if we see that 10% decline of ejection fraction is only 9.1% in PH-arm and 7.8% in H-arm. So the pertuzumab did not appreciably increase cardiotoxicity. So this the significant PCR benefit with dual blocker aligns with the clinical trial data in neosphere, and lack of statistically significant OSR EFS advantage is likely due to small sample size and limited events. Non-randomized retrospective design, as I mentioned, the achievement is not well balanced, relatively short follow-up period, and our data supports the safety of dual blocker in a real world settings. So limitations already described in the discussion: small sample size, short median follow-up, retrospective nature, and single center data. Thank you.